Good evening. At the outset, I thank Dr. Jyotidev and his team for extending this opportunity to chair this session. I am very glad this is the second time I chair the session for Amit Gupta. Just I am introducing a formal introduction. He is a physician, a first GP. He had done MSc in Advancing Diabetes course, Director Center for Diabetes Care, and he is having association with IDF, Public Health, Epidemiology Interest Group, ADA, Executive Council in National RSSDA.
Thank you for kind introduction. So I am going to talk on a very important topic, and this topic is very, very simple if you look at a diabetes clinic. So I see in the hall senior teachers, professors, as well as the young budding doctors and practitioners. So to begin my talk, I would like to ask you, whenever the senior professors are on the rounds and they want to ask a question on diabetes and how you assessed the patient. So first thing they would ask, if they want to really screw you, they will ask, are you carrying an ophthalmoscope? So I think all the younger generation must have experienced that, and most of the time we would not be carrying that. And even if some smart gentleman carrying the ophthalmoscope, then you would be struggling to see the lesion. So you will be asking, Dikha kya? Could you see? So this is how the screening of retinopathy is done. And if I ask you that how do you screen your patients for retinopathy in this hall before I start my talk, that are you using an ophthalmoscope in your clinical practice? Are you examining every patient with an ophthalmoscope? How many? So still the same professor-teacher thing will be happening, and very few people. And how many of us are actually going to referring our patients for the diabetic retinopathy to a ophthalmologist? So I guess each and every one, but how many of your patients will actually go to the ophthalmologist and get it done? So many few of them. So here is the problem, that we know that diabetic retinopathy is a major complication, and still we are not able to screen and we are not able to see, detect the diabetic retinopathy in an early stage. The burden of diabetes I am not going to talk about. Millions of people living with diabetes, we all know, and there are different common complications of diabetes, but for very, I can see some of the diabetes educators as well. So what is diabetic retinopathy? It is a very simple thing. So diabetic retinopathy is a condition in which retina of the eye is affected, and the blood vessels in the retina is the main target organ, target part in the retina, which becomes either damaged or becomes leaky. And this happens because of our production of the vascular endothelial growth factor. And what happens that these abnormal blood vessels, they are very fragile. They can break and they can bleed, or they can cause scarring of the retina, leading to the permanent vision impairment or the blindness. So according to the presence or the absence of the retinal neovascularization, you can classify the lesions into two types. One is the non-proliferative diabetic retinopathy and the proliferative diabetic retinopathy. So to keep it simple, NPDR and the PDR. So NPDR is the early stage and the proliferative PDR is the advanced stage. So those who have ever attempted to look at the retina by an ophthalmoscope, they will know that how difficult it is to look into a undilated eye and look at the entire retina and find out the NPDR. PDR may be very, very much visible because advanced lesions, multiple lesions, you can say, yes, the eye is affected and easily you can identify. But NPDR is the early stage, which is, I think, most important one, because you want to prevent the complications there only. So if you look at the diabetic retinopathy, so the normal vision and the vision with the diabetic retinopathy could be like this on the right hand side of the screen. And millions of people, they are at risk of vision loss because of the diabetic retinopathy. There are different modifiable risk factors like blood pressure, glucose, lipids, BMI, the smoking, and all this can help in prevention of the development of the DR. And it is not just the DR. Often the diabetic retinopathy is seen as a window to the other complications. And we know that if there is a retinopathy, you should screen for the other microvascular complications like nephropathy as well. Or whenever if you incidentally happen to identify nephropathy first, then the first thing the nephrologist will do, go for a fundus examination, check for the retina, so that you are able to identify any risk of retinopathy. So you have neuropathy, dyslipidemia, risk of stroke, cardiovascular disease, and the diabetic nephropathy goes up if you already have a DR. And also the incidence of diabetic retinopathy increases over a period of time. So for those age between 0 to 24 years, more than 1 in 10 people with diabetes have diabetic retinopathy. And this is again alarming. So large number of people, they will be developing diabetic retinopathy as they become older. And diagnosis is not simple. So this is what I was talking about. So it cannot be diagnosed simply by clinical history taking. You may get some clue. The examination of the fundus, though one of the most common clinical examination, always widely advised by all the senior teachers and professors, but rarely practiced by the graduates as well as the undergraduates. So an ophthalmoscope is a tricky device. It is not easy to use with an undilated eye. So are there any options? So we will look into that. So if we talk about the prevention and the treatment part, so if you detect early, then timely treatment is essential. And diabetic retinopathy is a preventable complication of diabetes. So we all know that this is one complication like diabetic foot, which can be prevented. So 98% of the severe vision loss can be prevented with the early detection and the timely laser treatment. So good control of blood sugar level, BP as mentioned earlier. Again, the treatment options are very limited. Either you go for a laser surgery to seal off the leaking blood vessels, or you do a vitrectomy, remove vitreous gel and the blood from the leaking vessels, and you use vascular endothelial growth factors, which are multiple. They block the VEGF, and this slows the growth of the new blood vessels, and that can stop damage from the abnormal blood vessels. And these are the different drugs which are available, like ranibizumab and faricimab, and the ophthalmologists, they are using routinely. I guess diabetologists are not giving injections because it requires proper training and proper facility, and most of the time it is done by the ophthalmologist. So why there is a need for diabetic retinopathy screening? Because it is a preventable cause of irreversible blindness, reduces social and the economic burden on the person, and if you are able to prevent the visual loss, you can actually improve the quality of the life. For example, a person who is driving a vehicle, engaged in a work where the vision is very, very important, somebody teaching, reading, writing. So if visual loss happens, then everything is impaired. This is very, very important document, and as a National Executive Council member of the RSSDI, I am proud to present this document to you. This is the diabetic retinopathy screening guidelines for the physicians given by the RSSDI in association with the Vitreoretinal Society of India, and you can see all the luminaries who have contributed to the development of these guidelines. So it identifies what is the role of physician in screening. So physician is often the first healthcare professional that people with diabetes, they will go and encounter. And this gives you an opportunity to screen at your clinic only. And patients having DR will be, if you can identify them early, you can refer them for the management. And at the same time, if you see that the blood vessels are normal, there is no retinopathy, you are avoiding unnecessary referrals to the ophthalmologist as well. So both ways it is beneficial. So why we are saying, so RSSDI consensus statement is very clear that physicians, we are the first point of contact for people with diabetes. We can provide the opportunity for the opportunistic screening for diabetic retinopathy, and we can identify people with referable diabetic retinopathy for early referral. So when to screen and how to screen, so RSSDI guideline document is very clear. So if someone is having type 1 diabetes, so you screen the first eye examination after 5 years. So after the diagnosis of type 1 diabetes, the first examination is recommended after 5 years. Type 2 diabetes, at the time of diagnosis and thereafter every 1 year, you go for the screening of retinopathy. In pregnancy, so whenever the patient presents with diabetes, you screen, and if it is a planned pregnancy, then you would like to screen before the conception. And the follow-up can be individualized based on the presence or the absence and the severity of the retinopathy. And diabetic retinopathy severity, you can only two things. If there is no DR, only annual follow-up is required. But if there is a evidence of diabetic retinopathy or diabetic macular edema, that is the DME, it requires immediate referral to the ophthalmologist, because timely intervention can save the vision of the person. There are multiple risk factors. As the age increases, if the duration of diabetes is more, blood glucose level, they remain uncontrolled, dyslipidemia is there, BP is uncontrolled, and pregnancy with type 1 diabetes and gestational diabetes, they are the risk factors where the diabetic retinopathy increases or the severity of the DR increases. So this is the usual flow which happens, but now we have seen the challenges, what can be the different challenges. So what can be done? So I am talking about a AI-based fundus camera. So India, we have now multiple people who have these AI-based fundus camera available in India. And I am also using one such camera with in my center, and many of you may also be using. And these and how they ease your workflow, let me show you. So this is one of the Fundus on phone, smartphone enabled handheld non-mediatic camera. So you need not to dilate. So I have my own clinical experience of using this camera, and in 95% of the patient, you can get good quality images which can be graded by the AI without any dilatation. So there is no risk of precipitating any kind of glaucoma, which may be undiagnosed in these patients. It is a portable device, can be used handhold or can be mounted on a platform. And offline integrated AI algorithms are also there. So even if you are operating a device in a remote area where the AI is not available, where the internet is not available, still the algorithm will work because it has the memory which the AI can actually play the role. So validated to be the best performing portable retinal camera. So I will show you some of the advantages because it is a non-mediatic, so you need not to dilate. Less expensive. Camera is focused through the pupil in the dark using infrared light that allows the patient's pupil to dilate naturally, and a flash is taken before the pupil constricts. And typically photographs of 45 to 60 degree fields of the retina, 5 overlapping fields will cover to same or slightly greater area of the retina than the standard 7 field photography. So it is a 5 field photography than the standard 7 field photography, but still you are able to discover a lot of major complications in the main areas. It is much more sensitive to the light, and cost per person is substantially less. So these are some of the images which you can see are captured on this Fundus camera, and very clearly you can see the lesions in the eye which are being demarcated and highlighted in the blue in this photograph. So these are the lesions which are highlighted here with the blue halo around them. This is how you handheld this camera, and you operate this one and identify the different lesions. So referable DR, as we define as the moderate NPDR or higher severity, or the presence of the CSDME, that is the diabetes macular edema. So they are the indications that you need to refer. So AI generated reports automatically specifies whether you need to annually follow up the patient or this patient requires some kind of the referral. So these are some of the pictures captured by this camera on Fundus on phone NM10, and you know that the internal fixation and the auto montage for a wider field of view. So 5 field view, then they are put together by the smart technology. So this is how this AI imaging is being done. So you will ask that how reliable it is and how easy to use. So I can tell you that it is easy to use, and there are studies, and all trials clinical endpoints, they exceeded minimum mandated sensitivity and the specificity by the US FDA. So the US FDA specifies that if you want to build an AI based fundus imaging camera, then it must be having a sensitivity of 85% and specificity of 82.5%. And in different community setting, diabetes centers and the hospital settings, the sensitivity of this fundus camera varies from 93% to 100%, which is quite good. And specificity is from 86.7% to 92.5%. So I believe it is much, much better than what we do in our clinical practice with a routine ophthalmoscope with a undilated eye examination. It can be generalized in different ethnic populations. So Medios was found to be comparable to iArt and IDX-DR AI in Peninsula and the Armenian population. So the performance was comparable when run on desktop camera images. So there are different diabetes centers where the study have been done and published. For example, a simple one of the SMART study, then you have diagnostic accuracy of automated diabetic retinopathy imaging study in Poland, 900 patients, 297 patients and 807 patients. And you can see the sensitivity more than 90%, in fact 93% in one study in India, and another it was 98.8%, while in Poland, again 95% sensitivity was there, while the specificity again 92.5%, 86.7%. In Poland, it was 80%. If you look at the community setting in India and another 3 regions, you will find the sensitivity as well as the specificity, they are within the range which is specified by the FDA for approval. This is another study, Medios DR AI study 1, and 900 subjects, prospective study. Device used was Remedio Fundus on phone NM10. offline DR AI versus image grading by 5 retina specialists. So you took, in this study what was done, the pictures were taken by the fundus camera, analyzed by the AI, and the same pictures were given to the retina specialist. And the sensitivity by which the retinopathy was picked up by 93% and specificity was 92.5% for referable DR cases. So the Medios AI has a high sensitivity as well as specificity in the detection of the diabetic retinopathy using NM retinal images. Another study published in the Indian Journal of Ophthalmology, this is Medios DR AI study 2, and again the images, they were graded by 2 vitreoretinal surgeons versus the AI graded images, and you can see the sensitivity and specificity 98% and the 86% respectively. So AI based software had high sensitivity and specificity in detecting referable DR. So important thing is that the ophthalmologists, they were supposed to pick up each and everything, even if it is a minor retinopathy, but the AI was very close to the grading done by a specialist in these cases. Another study which is done in diabetes centers in Poland. So device used was Topcan camera and the Medio offline DR AI and IDX DR AI versus image grading by 3 Polish retina specialists was done and 3 certified Indian graders. So for referable DR and sight-threatening DR cases, so both the AIs achieved satisfactory accuracy with few false negatives. So false negative cases were there, but the cases, they were not missed. So sensitivity was very high. So you may get occasional cases where you find some lesions on the retinal images, but when you refer to the ophthalmologist will say that there is nothing wrong. Everything is okay with the eye. So I think that is not, there is nothing to lose in such a case, because you are not missing the lesions. Maybe you are over-diagnosing in some of the cases where the AI may falsely say that, yes, the retinopathy is there. In community setting, so you can take this fundus camera to the community as well, and you can see again the offline DR AI images graded by 2 vitreoretinal surgeons, and sensitivity as good as 100% in the community setting with a specificity of 89.55%. So the robustness of the offline AI algorithm was established. So I was saying that this camera can be used even in the offline mode as well. So even if there is no internet connection and you are in a remote area or you are struggling to get a connection, still the AI tool will work. This study was again done in community setting and the similar kind of results. So I will not go into the details of this study. And another community study in Dominica, where you will find the study again supported the AI for diabetic screening in real world setting, matching specialist accuracy. So this is one area where we can say that now the AI has established its reputation. You can say the AI has now earned the confidence of all the doctors and the practitioners, and confident in this camera using artificial intelligence. You simply screen, no lesions, follow them annually. If there is a lesion, if it is a NPDR, probably you can take a clinical decision, but if it is a proliferative diabetic retinopathy, you have to refer that patient to a specialist for the intervention to prevent the blindness. So AI for detection of referable DR. So Medios AI generates a referral point in 10 seconds. You get a report which is easily available to you within 10 seconds. So waiting time is very, very less. And high sensitivity and specificity has been proved in multiple studies. And now I think many of clinicians sitting in this room, they may have also experienced this camera or using this camera in their clinical settings. So Medios AI holds promise for a scalable solution, as it provides instant reports and overcomes several barriers which are associated with current technology for the screening DR, glaucoma and the AMD. One thing which I did not mention is that now the newer algorithms, they also are able to give you the CD ratio. And on the basis of the CD ratio, you are able to predict whether there is a possibility of a referable glaucoma or not. So many of the time report will say that yes, this patient is a glaucoma suspect. So when you suspect glaucoma, you can again refer the patient to the clinic, to the ophthalmologist. So with this, I would like to conclude my talk. Thank you for your patience listening. So diabetic retinopathy may be invisible, but its impact is very, very profound, and it steals sight silently. So if we act in time, we can prevent this complication, and now we have tools which we can use to ease our workflow, and it can be easily integrated in any diabetes clinic or hospital. So thank you very much. So now the Sun Pharma has the marketing rights for this fundus camera. Thank you very much.
Thank you, Dr. Gupta, for your precise, wonderful talk. It's really amazing to know the sensitivity with the AI-assisted fundus camera is 93.5 to 98%. But I have one question, whether it is useful only for diagnosis or follow-up and review.
Sir, if a person is not having diabetic retinopathy, then you are probably going to follow up the patient as per the RSSDI VTRI guidelines annually, and once you have diagnosed the patient. And in type 1 diabetes, first screening happens after 5 years. But once the patient has developed advanced retinopathy, then probably this patient is better handled by a ophthalmologist, because he may require some kind of intervention. And in a already established case of retinopathy, the AI will only tell that there is a retinopathy and or not. And as a physician, we are not going to do any kind of intervention. So it is wise that we screen to look for the early lesions. And if you look at the early lesions, then the patient can also get motivation to improve glucose control, improve blood pressure control, quit smoking, reduce weight, which are the other risk factors for the advancement of the diabetic retinopathy. So idea is to screen, and if there is any treatable lesion, then it should be treated in time, so that visual impairment can be prevented.
Have you come across macular edema following a high dose of pioglitazone?
Sir, I think this happens when you give pioglitazone at a very high doses and over a very long, and this is a dose-dependent effect. So it doesn't happen that you start today and tomorrow you will see diabetic retinopathy. But whenever you have patients which are on pioglitazone, and maybe also the hydroxychloroquine, so you would like to see some changes in the retina, right? So it is wise that you are cautious about this thing and you are regularly screening them.
Any adverse cardiac event with the anti-VEGF? Anything?
Sir, so anti-VEGF, so right now, sir, I can say that I am not an expert in that area. So, and because most of the time we don't give VEGF in our clinical setting and we are referring patient. So right now I am not in a position to comment, but I think these agents have done wonder in preventing the blindness in patients with diabetic retinopathy.
Thank you for your clarification. Just one question, if anybody has got, please. Okay, no more questions. So thank you very much.
Thank you, sir.
Thank you, dear Chairperson and Speaker.